Hello and welcome everyone to this live breakout from transcatheter interventions online on optimizing large bore venous closure PerQseal in the real world practice. My name is Vasileios Panoulas. I'm one of the consultant cardiologists at the Royal Brompton and Hertford Hospitals in London in the UK. It is a great pleasure today to be joined by two exceptional colleagues. One of them, Rutger-Jan Nuis, a consultant cardiologist at the Erasmus University Medical Center, Rotterdam, working closely with the structural team there. And of course, someone that needs no introduction, Mohamed Abdel-Wahab, an interventional cardiologist at Leipzig Heart Center with extensive experience in structural intervention. Today's breakout is supported by Vivasure Medical, and we will try to recap the objectives from this session. In essence, we want to try and understand the advancements in large bore venous closures and see always why there's this need. To discuss the best practices for PerQseal in clinical scenarios and also review future directions in venous closure technology. We encourage all of you to actively participate, share your thoughts, insights, and questions using the Q&A box below. As always, with every online session, your engagement is vital, and we really look forward to addressing your questions at the end of each session. So I will kick off the session with my first presentation on the evolving landscape of large bore venous closure. This is my disclosures, and we move on to the next. As we all know, there has been an absolute boom in recent technologies that involve accessing the venous system. One of the most commonly used technologies is the transcatheter edge-to-edge repair. And here you can see the mitral clip and the PerQseal systems. We move to the next. For TIO, mitral clip uses a 24 French steerable guiding catheter. We have also the tri-clip. I use a 25 French steerable guiding catheter, and the PerQseal Precision from Edwards, I use a 22 French guide sheath and steerable catheter. Of course, there's not only the TIO technologies. If we move to the next slide. There's also the transcatheter mitral valve replacement therapies. And as you can see here, the most commonly probably used is the Vox system that has a 20 French size, but there's a wide range of devices out there. You can see the Edwards valves, you can see the highlights, you can see various approaches, but some of them started also, for example, with Intrepid, started the transapically and then moved into the transeptal space. Some of them going all the way up to 35 French, but normally with a range between 25 and 30 French. The aim is essentially to try and get those devices down to probably around the 25 French size for venous closures. We move to the next slide, please. What about cardiogenic shock? It's not only the structural interventions, there's also big venous access needs for patients that are treated with cardiogenic shock. In particular, if we talk about the support provided for the right ventricle, we all know the Protect Duo cannula. That is basically a system that drains blood from SVC and pumps it out in the pulmonary artery, and can also be connected to oxygenator, but as a result, it's quite a big French device. It's a 29 French venous cannula. We know the Impella family of devices, very well known for the left-sided devices, the CP and the 5.5, but also there is a right-sided support, and there's the Impella RP that used to be implanted from the right femoral or left femoral arteries with a veins, with a 23 French size. And also now there's going to be the Impella RP Flex that will be able to be inserted from the jugular. Of course, when we all do venous cannulations with ECMO, we use venous cannulas up to 25 French. And another field, of course, that is evolving, and there's phenomenal technology, is pulmonary thrombectomy. One of these very famous systems is the Inari flow retrieval for thrombectomy. And these normally use the 16, 20, and 24 French sizes. And yet again, it's a system that probably needs a dedicated venous closure device. Now, what do we have, however, in our list of devices for closure? One could say that we started with manual compression, but as we move on to bigger sheath and to procedures that require heparinization, and ideally you don't want to reverse at the end of them, you don't want to be pressing for hours because that can lead to DVTs after prolonged immobilization. And obviously, big complications such as big hematomas that can be avoided with current technologies. Traditionally, we have been using suture-based techniques, and these subcutaneous suture techniques used to be most often used the figure of 8, as we call it, or Z-stitch. And you can see there the two images. But of course, there was also purse string suture that could probably be used up to 26 French sizes. These are obviously not perfect. You can still get hematomas depending on how you deploy that suture, because in essence, it's a pressure using the subcutaneous tissues on the vein. Next, please. In terms of more dedicated devices, even though the PerQseal or PerQseal, whatever we want to call it, which is a blue-colored now device from Abbott, delivers that sliding knot and has been extensively used in arterial closures. There has been a big study showing that it can be used also for venous closures, in particular for TIO, for MitraClip, or TMVR with Edward Sapien. And it seemed that in this particular registry, there has been quite a low number of complications, 2 large hematomas, 6 small, and 2 DVTs. So this has been used as a technology. However, it does have the limitation that is approved only up to kind of 25 French sheath sizes. And it might have more difficulties in being applied in bigger access sites. However, we have a new device now, the PerQseal Elite, and you can see in this slide the development of the devices, the history of the pad space closure, how it began and how it has been modified over the years to facilitate a much easier closure for particularly those venotomies that are on the bigger end of the late 20s French size. Next slide, please. And even though we will speak in detail on the next slides and speakers, you can see here that the Elite Venous factory outcomes have been pretty good, with all device-related complications only down to 5.7, only 1 deep vein thrombosis, and 1 hematoma. But also what's very important is the efficacy measures, that you can see a very quick time to hemostasis. And this is something that is important for those patients to avoid also manual compression that then can lead to potential DVTs. Next, please. And with that, I would like to thank you. In essence, we're talking about an evolving field. We see that there's a lot of technologies, both in the structural world, but also in the cardiogenic shock world, in pulmonary hypertension, that have been using those venotomies, large venotomies. And I think it's important for us to highlight that this is an evolving space. A lot more valves are to come, valves in tricuspid, valves in mitral, and we will have to be dealing with probably late 20s French sizes holes in the years to come. I would like probably to move on to our next speaker, Rutger-Jan Nuis, who is going to give us a little overview about the Elite closure device. Rutger.
So thank you very much, Vasileios, for your extensive overview of the large hole venotomy closure strategies. So for the next 10 minutes, I'll be speaking about the PerQseal Elite vascular closure device only. This is a dedicated device, not only for large bore arteriotomy closure, but also for large bore venous closure. And it will be commercially available in mid-2025. So it's, I guess, important to discuss the innovations and clinical evidence of this particular device. So first of all, when we look at the device, it comes in 2 pieces, obviously a sheath and a patch delivery system, which are connected and introduced into one another. And then on the inside of the blood vessel, what we see is a patch appearing on the intravascular side. And this device is a single-use device for 14 to 24 French arteriotomies and for 14 to 26 French venotomy closure. As mentioned, it comes into the vessel and therefore it closes from the inside of the blood vessel, thereby minimizing bleeding during deployment. And if we carefully look at the animation on the right, we see the patch, and on top of that, on the extravascular side of the blood vessel, there is a locking system. And both of these components are fully bioabsorbable after 180 days. And therefore, this device really returns the artery to its natural state with a minimal footprint. But to me, the most practical advantage of this system relative to other devices is that it does not need any pre-procedural step, as we are used to when using or applying a suture-based technology or a plug-based technology, where we need to assess the arteriotomy depth before we create our large hole in the artery or the vein. So with this device, you could consider to go to the ICU and even percutaneously remove cannulas from ECMO patients or Impella systems without the need of a pre-procedural step. So what happens with the patch when it is implanted into the blood vessel? So if you take the patch and you look at the left image here and you put it under a microscope, you will see a textured layer. And this is designed to really trap the blood cells and the platelets when the patch is delivered to the blood vessel. And the platelets get activated, obviously, when brought into contact with the collagen fibers of the wound itself. And therefore, platelet aggregation results in more physical binding between the patch and the arteriotomy site. So that's really the detailed explanation of the device. Then what happens after an implant? As mentioned, it is fully bioabsorbable. So on the left, we see an animation of a freshly implanted patch. In the second image, we can appreciate that after 32 days, the patch is fully encapsulated. And after 90 days, the implant has extravascular vessel remodeling. And in the last phase, at 6 months, we can appreciate that the implant is fully absorbed and the vessel is restored, again, leaving no footprint behind. So this is a short animation of the device. When we take out our lard sheet, we introduce the sheath of the PerQseal and then attach the PerQseal delivery system. We bring it all the way into the blood vessel, and that's where it is parked before true deployment of the device. So it's a 3-step procedure. The first step is to clockwise rotate the first knob, and this will essentially pull back the sheath. And this results in the release of the patch in the blood vessel. Then you pull on the system gently, and this is where the tactile feedback comes into play, where the patch really is opposed to the blood vessel. And this will be the moment where you see no residual bleeding. The next step is to clockwise rotate the second knob, and this will result in the appearance of a second component that sits on the outside of the vessel. And then the last step is to remove the wire and release the delivery system from the device itself. So this slide has been shown before, but if we look into a little bit into detail of it, this is the evolution of the PerQseal device. That goes back to 2013, when the first frontier study was designed and performed. And after that, multiple iterations of this device were tested in multiple CE mark studies. And now we are working with the PerQseal Elite system in 2 parallel studies. The first study is the Elite Arterial study, which basically assesses the safety and efficacy of the system in large hole arteriotomies. And the second one is basically the same, but then for venous closure. So in both studies that run in parallel, Nicolas van Micham is the PI. Around 100 patients are included in both studies. All patients are treated in Europe, obviously, for CE marking, and the follow-up duration is for 6 months. Both studies are single-arm performance-based control studies with a primary safety endpoint of major access site complications at 30 days in the ELITE study and major and minor access site complications in the Venous study. And the primary efficacy endpoint is the time to hemostasis. And when did these studies started? Late 2023 and early 2024, and we expect final results at the end of this year. So these are the sites that are currently enrolling patients in Europe. The slide is not complete, but sites are in Germany, in Denmark, and in the Netherlands. And if we look at the baseline and procedural outcomes of both studies, on the left, we have the ELITE arterial cohort with 62 patients. This was an interim analysis presented at TCT last year. On the right, we have the ELITE Venous population. And on average, patients were 80 years old. The majority were male. Most patients were treated through the right. And patients underwent a TAVR in most of the cases, or a TEER when it comes to the Venous study. And the average dimensions of the artery, the common femoral artery, were 9 millimeters, and the common femoral vein were 12 millimeters. But most importantly, as we can see in the bottom of these tables, the outer dimensions of the sheath in the arterial study was 18 French, and in the Venous study, it was 23 French. So these were the outcomes again in the interim analysis. If we look at the ELITE arterial arm or study, device-related major complications did not occur. Device-related minor complications did occur in about 10% of patients, and these consisted of pseudoaneurysms and hematomas, both of them clinically not relevant. And in the ELITE Venous study, all device-related major and minor vascular complications occurred in 2 patients only. And then when we have a look at the efficacy outcomes, this is what matters to operators as well, because it may take some time more if you struggle with achieving patent hemostasis. For the arterial study on the left, we have an average time to hemostasis of 2 minutes, and 2/3 of the patients had patent hemostasis within the minute. On the right-hand side, if we look at the Venous study, average time to hemostasis was a matter of seconds, and 91% of the patients had complete hemostasis within 1 minute. So if we conclude, this was only a study that had interim analysis. The final results will be presented expected at TCT this year. And the initial first-in-man PerQseal ELITE arterial and venous experience suggests that the device has safe and efficacious performance. And further enrollment in both studies will improve our understanding of the next generation patch-based technology. Again, data will support CE mark approval in the first half of this year, and the final data will be presented most likely at TCT this year. So back to you, Vasileios.
Thank you very much, Rutger, for this very nice and detailed analysis of the innovation and some of the outcomes that we've seen. And I think now it's time to go and see it in practice. And maybe, Mohamed, you can show us how it's done and maybe show us some tips and tricks on how to kind of optimize the device, because obviously every device is just a tool, and unless we know how to do it, we can have complications. Floor yours, Mohamed.
Yeah, thank you, Vasileios. So I'll try to summarize maybe a few practical tips for the venous system, which is the main topic of the session. So you've seen, of course, how the system looks like. It comes, as has been said, in 2 parts: a sheath and the patch holding system. Importantly, and I think this is why the system has now been able to be tested and used in the venous system, is that the anchor mechanism has been improved, which is probably important to allow this patch to be anchored in the thin-walled venous system. It's also utilizing a bigger guide wire, and the sheath has a little bit improved compared to its predecessor version. As you've seen, there are two studies that are currently enrolling in parallel, the arterial and the venous study. And obviously, our current experience stems from the venous study. The device is like the EDITA devices has not been approved yet, as you've heard. It will be probably approved anytime later this year. But our clinical experience stems from this Venous study. And this is why it's important just to mention it briefly or to reinforce a couple of things. So 14 to 26 venotomies are allowed to be included in the study. It's a single-arm study. The primary safety endpoint includes major and minor access complications at 30 days. And the primary efficacy endpoint is time to hemostasis. And importantly, it's the same device that we use for the arterial access. This may change in the future. We may be able to get bigger devices for even bigger venotomies, but currently the device that we use for the veins is the same device we are using for the arteries. You've seen this video a few seconds ago. So I'm sure it's also still helpful to have a look at it a second time, because the majority of you probably are not familiar with the device, so you don't need to pre-measure anything. You exchange your sheath or your catheter for the sheath that has been, I have to go back. I'm not sure why it moved by its own. Let's go back. Yes. So you exchange the sheath or your delivery catheter with the sheath of the device, and then you introduce the patch, and then there are three rotating knobs. The first knob is there in order to get the sheath a little bit out. It's still in the vessel, but it's exposing the patch. Then the second step is to apply traction to get the patch on the vessel wall. And then comes the second knob, which applies the anchoring mechanism or the locking mechanism in order to hold the patch in place. And then the third and final step is to remove the wire and to apply torque on the third knob in order to remove the system. One advantage of the system is also that it's still reversible at a certain time point. So when the patch is applied to the vessel wall, you can still very nicely, and we will show this in a moment, check for hemostasis, maybe improve the apposition of the patch on the vessel wall. And then if you're happy, you can release. And if you're not happy, the system can still be withdrawn from the body. You still have wire access and you can think of something else. So this is maybe an important advantage that we have with the suture-based devices, but we don't have, for example, with plug-based devices. This is how it looks like in real practice, and this is a case done in Rotterdam. And you can see here the exchange or the introduction of the dedicated sheath on your workhorse wire. You need to measure, of course, some depth, and this is something that you don't have to do beforehand. So you just introduce the sheath, it will bleed through the sideway, then you withdraw the sheath until bleeding stops. This is your depth. In this case, you can see it's around 3 centimeters, and then you introduce the sheath back again, adding 4 additional centimeters. After that, the wire remains in place, and you introduce the patch-holding delivery catheter, just pushing it into the sheath, holding the sheath in place, and then after that, you start exposing the patch inside the vessel by rotating the first knob clockwise. So you'll see now that the operator with his left-hand side, he's stabilizing the system, and with the right-hand side, rotating the knob in order to get the sheath a little bit backwards, exposing the patch. Then the operator is applying some traction, and importantly, getting also the right traction in a correct angulation until he feels a certain tactile feedback. This can also be checked through the side way. So if bleeding stops, then you're at the vessel wall. And now you can see that the final step is removing up the wire and using the third knob in order to release the device. There are a few practical tips that we started to learn through our experience, which is of course still limited. But one important tip, which applies to both venous and arterial side, is the proper deployment angle. So you can see here on the right-hand side, the long angle deployment, which may lead to some malapposition between the patch and the anchoring device, which can lead to suboptimal hemostasis or even dislocation of the device. So the proper deployment angle is a little bit higher than we're used to. So it's around 45 degrees. And this is important while applying traction to the device. And most importantly, while applying the anchor of the device. Yeah, so again, to the practical tips, I'm not sure what you heard, but let's go through them again. So back bleeding, obviously, it will be slower, but it's still reliable. Traction should be gentler. And the most important tip I would give you is to use ultrasound during puncture, using both short and long axis to obtain a nice central puncture, because this helps you apply the device in a better way. But more importantly, we've been using ultrasound regularly during application of the device to help us see the location, which you can see here. This is the device inside the vein when it's exposed and it has not been withdrawn back to seal the venotomy site yet. And on the picture below, you see here, after applying traction, the position of the device on the venotomy side. You can even assess for hemostasis, both clinically and also using color Doppler. And this is really very helpful because it can help you also adjust your tension and maybe optimize the position of the patch in order to optimize sealing. This could be even more important, as has been mentioned. If you are going to apply this in a patient maybe that you did not puncture by yourself. So if you're going to the ICU in order to remove an ECMO, for example, or any type of device, then this could be extremely helpful in order to be sure that the device sits at the correct position. You've seen these data from the interim analysis of the Venous study. So it's interesting to see, of course, that 80% of these procedures were edge-to-edge procedures, probably also related to the size of the sheath that are allowed to be used here. The time to hemostasis is actually 0, so the system works very fast. And it's very encouraging to see very, very few events in these initial 47 patients. Of course, still the numbers are small, but it's very helpful. We looked at the patients that have been enrolled in Leipzig, and these are 17 patients. You can see here that they are elderly patients, are as expected, 60% of these were male patients. And this is more or less reflects the same what we see in the study as a whole. So almost 90% of the patients enrolled in Leipzig had edge-to-edge, evenly distributed almost between mitral and tricuspid. What I find interesting is that, and we expect this from these procedures, that almost 90% of these patients were on oral anticoagulation, which was continued throughout the procedure, and still there were no big issues of achieving immediate hemostasis. And these are some examples. Of course, patients who are recruited in the study are very rigorously followed up, which is maybe different than what we do in real world practice. So all of them get an ultrasound at the next day. And you can see here some examples of how the device looks like on ultrasound. So it can be easily identified. You can see here that it sits abutting the venotomy side on the anterior aspect of the venous wall. So it can be easily identified and easily checked for any issues. So to summarize, the experience, of course, with the venous system is currently confined to cases in the first-in-man study. It's the same device and the same steps as the arterial use, with some minor modifications as mentioned. Deployment angle appears very important. I would encourage you to use ultrasound for puncture and during application, maybe during follow-up. At least this is part of the study.
I think it was very clear that from the data he presented, there is a few steps, isn't it, to the device. It's not necessarily something that you can do with your eyes closed, but I think you have to do your punctures with ultrasound. And I guess, all of us now, particularly the younger generation, has moved into ultrasound guided punctures. And a lot of the times we use it for closure. I personally really love my ultrasound, and I really like to confirm that, if I use plug-based devices, that the whatever anchor it is or patch is actually well attached to the inner wall and not hanging out somewhere in the posterior wall stuck to some calcification. So I think it's a very important comment to pass on to people that want to use this device. I think is to potentially use ultrasound both to get the optimal access in the beginning, but also towards the end to make sure that they can navigate. And you can see that patch, it's quite big. It's a bit like a UFO just starting to climb up. I know, Mohamed, you kind of said that you use ultrasound for all your closures. And I guess that's kind of key with this device. Just make sure it gives you that extra security. You have some tactile feedback, but I guess obviously seeing it also in the ultrasound gives you that extra reassurance that then when the lock comes, you will have a great result.
In the venous side, probably we're not very much used to it now. It's still probably a much thinner wall, and you can maybe, if you're not used to it, you can miss it, and you can think you maybe have to pull a little bit more. So it gives you really like a visual help as well, which I find very useful.
Absolutely. I think the veins also tend to tend a lot more compared to the arteries. And that sometimes always was making me wonder the efficiency of how the suture-based devices are going to work, particularly with all this tenting going on. It seems that, from the study, I kind of quickly flashed up that the results seem to be quite encouraging also for the suture-based devices. But I guess it's always good to have alternatives. And this patch-based device probably, it's much faster. You don't have all this oozing left over. That quite often is the case in all these cases that you want to keep the heparin going, basically. We don't have any other questions. I don't know if you would like to add any more comments with regards to your experience.
So I think that what the importance of the angle of deployment of the PerQseal is, I recognize it. And what happens in the blood vessel is important also to understand, because you might think if I deploy very horizontally, then something would happen to my intravascular patch. Well, at first, that's not the case. The issue is, as Mohamed showed, the extravascular component that sits more vertical than horizontal on the blood vessel, and that creates the stretch on the internal patch. And if you realize that and you experience that, you also realize that it is so important that your axis is really at 12 o'clock, because if your axis is at 3 o'clock, how would you safely and correctly get that patch into the vessel? So that's, I would say it's almost not done to not use echo with these procedures, but that's my view.
I think that's a very important point, and that applies also for other closure devices. We all know that if you deploy prostal at 3 o'clock, you probably will end up with bigger lumen narrowing as well, because you just try and grab, and always a lot of failures. And what you describe is just so important. But it's difficult. How do you teach ultrasound guided access? I mean, you see a lot of people trying to use ultrasound on live cases. You never see that tip of the needle getting in the artery or the vein. I mean, the artery, they're a bit stiffer, and you can still see it sometimes tenting. You see the tip of your needle, but you don't have blood coming back. In the veins, actually, that's even more challenging with all the tenting that's going on. But I guess there are ways and techniques. Recently, I kind of had the idea of, once the wire is in over your needle, to just ultrasound the whole course of the wire. And then you can actually see at what o'clock you have gone in. But all these are just, little tricks for newer people coming on board. But they lead to success. And I guess, it's very important that we utilize all the catalog of things that we have in the cath lab to try and optimize our patients' care and closures, because that's very important. Now, do you guys think that there will be need for this device? It will replace, or at least maybe, have something special compared to what we already have? I guess the audience would like to know, how does it compare to the PerQseal? What is it gonna bring over and above the PerQseal in that space, in the venous space?
So as I mentioned before,
Let's start with
it's a simplicity that really counts, I think. I mean, especially in these venous cases, you're done within seconds. You don't need a pre-procedural step. So it not only makes it easier, but the versatility or the applicability of this device in other populations is interesting. For example, as mentioned before, if you want to remove the sheaths or the cannulas from an ECMO patient percutaneously, you could take 2 of these devices and you're done. Whereas as we do it now, I would use, for these kind of cases, a manta for the artery cannula and 2 or 3 sutures for the venous cannula, which is, well, in terms of material, you have to go to the supermarket to get all the material with you. And in this case, it's simple. You need 2 of these devices. And of course, something can happen, but that can also happen with my current strategy.
And also, I guess, if you're doing those closures bedside, I don't know, our ITU is quite interested in us going over there, so they don't have to move the patients in after removal of ECMO and stuff. So we do often this case on the bedside. And I can tell you, I think if you use a device like PerQseal or Manta for the arterial, for example, you have a lot less bleeding going on, rather than trying and put it. And, because sometimes when you put the ECMOs, you don't necessarily go with PerQseal up front, right? Because it might be a rescue case. And it becomes important to have a device that can easily seal the hole as you come out, I guess. Mohamed, what's your thoughts?
Yeah, maybe one important aspect also is, like, from the patient's perspective. Now, I mean, if we have devices that are extremely effective, and this could help also, like, increasing patient comfort. I personally get a lot of complaints from patients. The main thing they don't like after our procedures is the pressure bandage. Correct. So they don't want a pressure bandage. And even if you leave it for a couple of hours, it's the time where the patient wants, like, to start, like, mobilizing, maybe eating, maybe going to the bathroom, and so on. And with these devices, if they are effective, they prove to be effective, you don't even need the pressure bandage. And this maybe help also early mobilization, early discharge, and so on. And the patient population we are going to be treating in the future is maybe, like, a little bit more focusing on that as well.
Absolutely. And, I think we all heard some complaints even from the Z sutures, right? Figure of 8. I certainly had complaints about pain and, discomfort. And if you can have a device that can solve the problem without any pain, I think, obviously that's going to be the future. Thank you, guys. So unless you have any other burning comments, I think we might have to bring that breakout session to a close. Thank you both very, very much for your excellent presentations and for your insights and spending the time with us today. And thanks to every participant that kind of asked questions in the Q&A. and of course to Vivasure for sponsoring the session. Thank you very much, and I hope you enjoy the rest of the online course.